Hello and welcome to today's event, Meaningful Use Strategies, Tips and Tricks for Using Multiple Systems for Attestation. Today's session will review how using multiple systems will affect measures with thresholds, measures without thresholds, and clinical quality measures. My name is Kristen Monty. I'm T-Systems Marketing Specialist, and in just a moment we'll be joined by our presenter, Dr. Robert Hitchcock. If you have any questions that you would like to submit for the Q&A at the end of the webinar, click on the icon with the question mark and type in your question at any point throughout the webinar. We'll gather these questions and try to address as many as time permits at the end of the session. If we don't get to your question, we will follow up with an email to you one-on-one. We will have a recorded version of this session in the event that you want to go back and review the material, or if you want to share the presentation with a colleague who is unable to attend. I will distribute the recording of this event to all attendees. Dr. Robert Hitchcock uses his unique experience as both a physician and IT expert to guide strategic decisions for T-Systems solutions around key industry topics like meaningful use and ICD-10. He has over 20 years of experience in healthcare and more than a decade as a practicing emergency physician. And now to kick off our presentation is Dr. Bob Hitchcock.
Thank you very much. Good morning, everybody. Another in the webinar series about meaningful use, and I want to thank you all for taking time to join us. This part of the series is particularly interesting to me for several reasons. First of all, it will be a math lesson. So I'm glad that I do have a fifth grader at home to help me with fractions and percentages and things like that. Actually, she enjoys talking about this as well. We're going to go through today several things related to meaningful use in the setting of multiple certified systems. So we'll talk about what 2014 did and how some of the changes might affect hospital strategies. We'll talk about the advantages and the challenges of multiple systems. It is a double-edged sword. How to reconcile, which is the biggest concern for most facilities, is how they will actually get to attainment number-wise, and then talk briefly about clinical quality measures. And again, we will take questions at the end. So if you have questions as we're going along, please type them in the Q&A box. If I do see something pop up that's directly relevant to what I'm talking about, I will try and answer that as we're going along. The 2014 rules affected both Stage 1 and Stage 2, so there were changes to Stage 1 in the quote-unquote Stage 2 rules put out here at the end of 2012. And some of the biggest changes, though, were around Stage 2 with how it reflects for multiple system use. There are 4 measures that may have some implications for hospitals looking at an additional certified solution to add into their environment to help them meet these measures. The first is view, download, and transmit, or the proverbial patient portal. Essentially for Stage 2, and even for Stage 1 now, hospitals must provide patients online access to their medical records. That means that you need to have patient portal functionality. That patient portal, of course, could be offered through your enterprise vendor. Many of those the enterprise vendors do not yet have that solution, but there are a host of third-party solutions on the market, as well as many folks are looking to meet this with their health information exchange. And those health information exchanges are going to get certified. Because of the specialty nature of a patient portal, many hospitals are looking at adding on a solution just for patient portal, which would be yet another certified EHR in their environment, one that they would need to connect to the other EHRs. Similarly, summary of care is a measure. It's both in Stage 1 and Stage 2, but in particular in Stage 2, it requires electronic transmission of the transition of care summary. And again, this can be met with an HIE or other exchange, or with specialty systems that support direct technology and direct standards, which is essentially encrypted, secure point-to-point email. And in many cases, hospitals will be looking to acquire direct technology that is certified. So yet and now, increasing the complexity of the environment to meet meaningful use. 2 menu measures in 2014 for Stage 2. One is providing lab results directly to ambulatory providers who use your hospital lab. That's probably likely going to come from your lab system, which may or may not be from the same vendor as your enterprise EMR. And then e-prescribing as well is a menu measure for Stage 2 for 2014. And hospitals can use a standalone e-prescribing system, such as Relay Health or Doctor First, or one that's embedded in with one or more of their EHRs. So in reality, what we're looking at is as meaningful use progresses and the goal of the connected healthcare environment starts to become realized or at least put into practice, we're going to see increasing pressures for hospitals to most likely go with multiple systems. And so the reality of being able to continue to meet meaningful use with a single enterprise system is becoming more and more difficult. There are some significant advantages, though, to using multiple systems. And those are using systems that were designed specifically for the purpose that you're being used for usually means better adoption and better results. So for instance, CPOE in the emergency department. Well known that CPOE in the emergency department is very well adopted, 80% plus adopted, whereas CPOE in the inpatient environment has adoption rates below 40%. And that's from Leapfrog Group, an independent organization who's very supportive of CPOE. But furthermore, systems that are not really well designed for the function they're serving tend to lead to incomplete or inaccurate data collection, which really means that you're not getting anything out the other end. And this could be anything from your ED information system, such as T-System, down to an L&D system, a specialized radiology or lab system, e-prescribing system, patient portal, et cetera. Those that are designed specifically to do functions that meet meaningful use in a specialized way tend to have better results. By going with specialty vendors, you're not held hostage to one vendor, and I don't use the term hostage terribly lightly here either. And the more a hospital becomes a single vendor shop, it is easier in some respects, from contracting to perhaps even payment, to perhaps even integration challenges. But you also become very hostage to the whims of those vendors and what they're willing to supply. We are aware, for instance, that some enterprise vendors are going to release a patient portal which will not accept information from any other system besides theirs. It's this closed environment that's going to make continuing to grow with meaningful use very difficult. Multiple systems can also mean selective upgrades. Instead of massive rip and replaces every 2 years as meaningful use changes, you can selectively upgrade the elements of the systems that you need to meet the next stage of meaningful use potentially without having to go through that big bang. And furthermore, you can stage your upgrades. Even if you needed to upgrade everything in your environment, you could do it in a staged fashion rather than that big bang. There are some perceived challenges and actually some real challenges as well to using multiple systems. But one of the myths out there is that you can only use one system to meet meaningful use, that you have to have one certified EHR as the center of your meaningful use strategy, and that is completely and totally not true. Meaningful use fully supports your use of one or more certified system. Any combinations is permitted so long as you meet the requirements of having enough things to cover all the elements for which you're certifying. That means you can cobble together anywhere from 1 to, I've seen attestation with as many as 37 different certified systems. There's the myth that when I put more systems in to try and meet meaningful use, that I need to interface all those systems. And very clearly, there's no requirement placed upon a hospital to add additional interfaces beyond what would be necessary to meet meaningful use in the first place. What I mean by that is, in order to meet meaningful use, you have to get information into a patient portal, let's say, or you have to send a transition of care summary out, or you have to do a public reporting measure. Those are things that you're going to need to do anyways. In a setting of multiple systems, you do not need to build interfaces between your multiple certified EHRs, and you don't need to send those outbound information from all of them if you don't want to meet meaningful use. So you're not incurring any additional burden of interfaces or data sharing for the purpose of connecting those systems in meaningful use. And I'll talk about reconciliation here in a second and how that really doesn't require interfaces either. And then lastly, hospitals also believe I need to have all my data in one system because I do need to report out of one system, and I can't do reconciliation. There are several fallacies in that. First of all, with the exception of clinical quality measures, You are not limited to reporting out of one system by any means. You can do reconciliation in any fashion you'd like to, including manual. You could sit down with a pencil and paper if you'd like to reconcile and then report those results. For clinical quality measures, as we'll discuss, indeed you do need to report out of a single system, but there are some advantages in 2014 which make that a little bit easier. I want to talk now about result reconciliation, and here we get into the math part of this. And this is, okay, so if I am using more than one system in my environment, and I need to make sure that in the end that I meet the demands of meaningful use and I can check the boxes and get my check. Well, there are really two types of measures in meaningful use, and they have different implications for how you would accomplish these in a multi-system environment. Those measures are threshold and non-threshold. By threshold, I mean that they have a percentage attainment, like 80% of meds, allergies, and problem lists. And then the non-thresholds are either kind of yes, no, on, off, done, not done. They're very binary. And those are things like, do I have clinical decision support on? Did I send an immunization message? So those are very different in the way that you would approach quote-unquote reconciliation. I'm going to cover both those categories. Now, reconciliation proper, having to take data, not even data necessarily, taking results from multiple systems, only applies to those measures with thresholds, only applies to the numerators in those thresholds. And I'll talk about denominators here in a second. And reconciliation also applies to clinical quality measures, which is a special group, and we'll discuss at the end. Now, notice I said that reconciliation deals with the numerators. There's the question out there about all ED and observation method. What does that mean to me? How does that work into the result reconciliation, and what does it mean from a strategy perspective? Well, these methods are ways of determining what the patient population to which meaningful use applies to you is going to be. ED and observation method, again, only apply to threshold measures and only apply to the denominator. So what you're choosing is you're choosing the denominator of these, or the patient population. And by choosing whether to include your ER discharged patients or not, it has implications downstream, but it is purely a mathematical implication in the denominator, and may, though, also affect your strategy. So, for instance, the observation method eliminates from meaningful use you looking at ER discharged patients. That means for measures that deal with a transition of care or discharge, such as your patient portal and transition of care summaries, you must meet that measure solely through inpatient discharges because you're not considering ER discharges anymore. Conversely, if you were to choose the all ED patients method and ER discharges were in the denominator now, you could leverage your ED for those measures in place of or in addition to your inpatient environment. So choosing your method can determine your strategy for attestation, but it really only affects the denominator or the patient population to which meaningful use applies. So again, only threshold measures. For non-threshold measures such as public reporting, that applies to your hospital, not to the patient population of ER patients or inpatients. And lastly on this, I will say that some folks believe that if you go with the all ED patients method, then you must have a certified system in your ER. You must do everything on ER patients as well, such as report immunizations. That is not true. All you need to do to meet meaningful use is be able to check the box, and that's what we're going to go through next is the math behind that for threshold measures and meeting the measures with multiple systems for non-threshold measures. And hopefully, if I do a good job, you will see that indeed you do not need to apply everything to meaningful use for these. So I did have a question which I do want to address that asks if we choose the all ED option, do we have to include inpatients or is it just ED? And the answer to that is coming up here in a slide in a minute, which I will address, and the answer is yes, you do need to include inpatient discharges as well. And I'll go through that in some detail right now, and thank you for that transition. So there are two, again, types of patient populations you can look at, the observation and all ED patients method. Both methods include all patients discharged from an inpatient status. The observation method also counts into the denominator, or your patient population, all ED patients that were admitted or placed in observation. Essentially, all your patients who didn't leave your facility after the ED, but stayed for some reason. The all ED patients method includes all of your emergency department patients that received any care. So essentially, all your ED patients except left without being seen. The implications of this are, in the observation method, you have a smaller overall patient population, a higher proportion of inpatients, and you're high reliance on your inpatient EHR to drive meaningful use. This is honestly a strategy that many hospitals took for stage 1, looking for their certified enterprise EHR to meet meaningful use for them, and most were very successful. However, most are also recognizing that with the increased thresholds and demands of stage 2, that they may not be able to rely just on the inpatient EHR, even using the observation method. Again, the note on this, remember that e-prescribing, patient portal, and summary of care, because these have to do with discharges, can only be met with your inpatient discharges now, because you're not counting your ER discharges. Conversely, for all ED patients, you have a very large population, sometimes as much as 10 times larger than you would be using for the observation method. Gives you a little more wiggle room for error or poor adoption. You have a much higher proportion of ER patients. In fact, they are the majority of the patients in this population. And you have a high reliance now on your ED EHR to meet meaningful use. In this setting, for stage 2, summary of care can be largely met from the ED. You have to provide 50% of your discharges access to their medical records within 36 hours of discharge. Because of the vast number of ER discharges, you can most likely meet that measure just with your ER, but would almost have to include ER patients in that mix to get to 50%. Patient portal can also be largely met from your emergency department. Patient portal is at 50% of discharges. Summary of care is a little bit different, and only 10% need to go electronically. But again, you could meet that largely with your ED patients. And then e-prescribing is 10% of prescribed meds on discharge being met through an e-prescribing. You could use either your inpatient or ED population most likely. So you'll see that the choice of observation or all ED patients is a choice which can have an effect on strategy, and is probably a choice that should be made before really embarking down, in particular, the stage 2 route, because of the number of elements that have to do with the outbound transition of care. I want to talk now about measures with thresholds. In stage 1 and stage 2, there are measures that are common between those, and these should look very familiar to you. Stage 1 had a couple of eliminated measures with thresholds, and stage 2 added many more. Thresholds are a favorite of CMS because they give some flexibility in how hospitals can meet the measure. And again, it really comes down to, did you just mathematically exceed X%? Now, what I'm not calling out here is that things like the denominator for CPOE, or the way it's being measured, has changed, and it's actually not terribly relevant because there are different types of denominators for these threshold measures. There are essentially 3 groups of types of denominators, and these are important when thinking about measure reconciliation or the math behind this. The first type of denominator is unique patients. So the number of unique patients in your patient population that have a smoking status documented. That's one measure for smoking status. They are looking particularly at unique patients, or MRNs. There's also the idea of visits. If you think of it, it's kind of like unique visits is equivalent or is similar to unique patients in the concept perspective. Of course, every visit is pretty much unique. The visit denominators apply to things such as med reconciliation and summary of care. And then lastly, there's a denominator type with a threshold of total counts of events. That could be orders placed, results received, meds administered, those types of things. So the total number of things that happen. Those tend to be independent of unique patient or visits and can vary dramatically between patients. So the number of labs ordered or the number of meds ordered on a patient is really irrespective of the total visits count in your hospital or the total visits for that patient. And across visits, one patient might get one order and the other might get 50. So those are the three types of denominators, and they are important from the math that we'll discuss here in a second. Let's talk math then. Let's talk about result reconciliation, because often hospitals see this as a significant limiting factor in opening up their meaningful use strategy to include other certified systems that are not going to do something purely standalone and on their own. And so I want to just talk to you about the two types of groups, total events and non-total events, or visits and patients. Reconciling total events is relatively straightforward because each event in a system, such as an order placed, is in general unique. If it's not the case in your environment where you may have a single order being represented in multiple certified EHRs, then there's a little extra layer of reconciliation down here in pulling out uniqueness. That would look more like what I'm going to talk about for visits and patients. But in most cases, an order is a unique event that happens in one system, but you may have multiple systems placing orders in your hospital that are certified. So System A, pick your system, let's say it's your inpatient system, had 400 total orders placed. So your total order count, your total event count is 400. 200 of those met meaningful use. Those are your qualifying or your met. This gives you a result of 200 over 400, or 50% attainment of CPOE, let's say, in System A. In System B, let's say it's your ED system, you may have had 200 total orders, and of those, maybe 190 qualified, giving you an attainment of 95% in that environment. So now we have to figure out, as a hospital, how do I reconcile the results between these two systems so that I can report my hospital attainment. My hospital attainment is not 50%, it's not 95%, because I've already figured out that my denominator, or my patient population is included in here. I need to now figure out the math between these two. Well, the math between the two really isn't too awfully bad. I add the two together. Because the total events are unique between the systems, you add numerator and denominator, and you come up with 390 met out of 600, or 65% attainment. So reconciling total events that are unique in each system is a simple mathematical addition of numerator and denominator. And if you had 10 systems, you would essentially do the same thing. You would add the denominators for all 10, add the numerators for all 10, and your resulting percentage is your hospital attestation. That's what you report to CMS. So what's on the right is your goal. You need to exceed whatever set threshold there is for meaningful use. This makes it particularly easy using multiple systems because you can track on a daily basis and without any real complexity know how you're doing and look for opportunities in various systems to increase performance so that your overall result is increased as well. Reconciling patients and visits is, in fact, a little more difficult. However, it is not terribly difficult at all and should not be a limiting factor, which many facilities believe it is, because in many cases they just haven't sat down to think about how they might do it between multiple systems. The first thing you need to know in reconciling patient and visit information is to get a list of all of the things in the denominator. So if we choose something, let's say smoking status, and we're using the observation method, let's say, I would get a list of patients, probably from my registration system, that were either discharged from an inpatient status or were admitted or placed in OBS from the ED, and you'd get a list of unique MRNs. Very easy to do, very simple to do. Most registration systems can get that. If you had to go to two systems to get it, you could get a list of those visits in two systems and use a simple, even Excel formula to get the unique list of those. It's very straightforward, and if anybody's interested or needs it, I actually have some flyers with those formulas on it. So now you've got your denominator. Your denominator count in this case is 16 visits. That's your total uniqueness. Now this could be, again, patients, it could be visits. It really doesn't matter. Conceptually, now you've got your denominator. So the first thing you would do is go look in the system that houses the most information for you. If you're using the OBS method, that may be your inpatient EMR. Look at the visits that did not qualify. Which visits did not, or unique patients in this case, did not have a smoking status documented? In the system, these are 7. That means actually you had 9 out of 16 in the system would have met meaningful use, and that's 56%. In System B, what you do is look for those that did not qualify. That did qualify. So you know who didn't in System A, so let's see, what can I harvest from System B, let's say T-System. Compare those two quickly, again using a simple list compare. You see that there are 3 patients that qualified in one that didn't in the other, which now raises your threshold to 9 plus 3 out of 16, resulting in 75%. So this is very simple reconciliation, can be done through Excel. Excel can generally handle enough rows to do this for even a large hospital. For a multi-hospital system, if you do them a facility at a time, it's usually not a problem at all. And it's very, very straightforward. So conceptually, your denominator is easy to obtain. You have a system that's going to have the majority of your patients. If that's all ED patients, that's your ED system. If it's the OBS method, it's your inpatient system. Look to see which visits or patients fell out of that system, and thus go look at the other system to see how you can augment or add to your numerator. Very straightforward, just math. Measures without thresholds, and these again are the kind of yes, no, on, off, done, not done type of measures. Reconciling these is something that doesn't need to happen, but I do want to talk a little bit about the implications to the hospital. In Stage 1, these include things like running a patient list report, clinical decision support, public reporting, and the interaction checking, along with drug formulary. The Stage 2 measures without thresholds actually include all of those from Stage 1. In fact, the interaction checks and drug formulary are really hidden in Stage 2 under clinical decision support, so they're actually identical. So hospitals will have had some experience with some or all of these measures in Stage 1, and will have a pretty good idea of what to do in Stage 2. The requirements are different in Stage 2, but again, they'll have a pretty good idea of how to deal with them. Since there's no threshold for these, there's no need to reconcile. The hospital must demonstrate the ability to meet this measure from at least one certified EHR. It doesn't have to be all certified EHRs. You don't have to provide information on all patients in those certified EHRs. You don't have to report on all labs. You do not have to report on all immunizations. In the end, to meet this measure, let's pick syndromic surveillance. In Stage 2, to meet this measure, you must show that you have an ongoing submission of syndromic surveillance information to a public agency. That's it. It doesn't ask you to incorporate all your patients, and it doesn't say that you need to have feeds from every certified EHR. As long as you can comfortably say that you were in an ongoing fashion, we're sending information meeting the syndromic surveillance requirements to a receiving agency, you have met the measure. You can certainly do it from all of your certified EHRs. You can try and include all visits, all patients, all immunizations, and all labs. And that may be the right thing to do from a clinical perspective, but it's not necessary for meaningful use. You can look to leverage whichever system is easier, cheaper, faster, more complete, whatever the benefits are from the system. Look for the system that can get you there the fastest and the easiest. And then you can always look to augment and add this functionality in other systems afterwards. Now briefly, clinical quality measures. I'm not going to go into significantly great depth on this because this is a fairly complex area of discussion. And in the future, if there is a lot of interest in this, we can sit down and walk through clinical quality measures in more detail. There's a lot more technically to this. and a lot more variability in how hospitals are dealing with clinical quality measures. I just want to give you a background on the 2014 rules for clinical quality measures. There is a little bit of difference between Stage 1 and Stage 2. In Stage 1, CMS doesn't care at all about accuracy. You can report zeros. All you have to do is put down whatever your certified EHRs tell you, and I'll tell you how to reconcile for Stage 1 in just a second. Now, the one change to Stage 1 in 2014 actually was that after year 1, you have to report electronically from a single system. So if you're not in Stage 1, year 1, you look more like Stage 2. Accuracy does count for Stage 2. They put the burden of accuracy, however, mostly on the vendors, and that the vendors are expected to show that they can accurately calculate clinical quality measures with data, actually from multiple systems. Hospitals have the choice of submitting either all patients counted for their clinical quality measures or to sample. Now, sample makes it very interesting because sampling for a hospital can eliminate the need to reconcile by sampling only from one system as long as your numbers are big enough. So although accuracy is important here, reconciliation can be eliminated through the sampling process. The implications of this are slightly different on the technical side because you're sending out different technical specified documents for each one of these. If there's any technical folks on the line, it's QRDA 1 for the sampling and QRDA 3 for the all patients. But your vendors that are certified to do this, submit clinical quality measures and report on them, can do both. The vendors in 2014 are no longer required to certify for all clinical quality measures like we were in Stage 1, but when certifying, we must show that we can accept data from other systems. So they're putting some of the burden of reconciliation back on the vendors. Now, doesn't mean that connections don't still have to be made in those environments, and that may or may not be simple or straightforward. But again, you are given the opportunity with Stage 2 to do that sampling, so you may not need reconciliation. If you're going to reconcile, again, Stage 1, Year 1, you are to report exactly what your certified EHRs tell you for their clinical quality measures results. You can report zeros, and if you're using multiple systems, you sum the numerators and denominators. In that respect, it looks very similar to the three-column reconciliation of events that we talked about earlier. Take all of your reports from all your certified systems, add numerators, denominators, and exclusions if you have exclusions in those measures, and you report in your web-based attestation tool those results, those summed results. If you're beyond Year 1 for Stage 1 or in Year 2, you are mandated to electronically report in 2014. That said, CMS does not yet have the reporting tool up and running. And with the shutdown, I'm not sure where we're going to be, if we're going to be on time or not for electronic submission, but let's assume that we are. That means that hospitals are going to have to electronically send one file out to CMS at the end of their attestation period, their reporting period, and that system needs to be certified. So you are, if you choose to, going to need to figure out how do I get data from other systems into this one. Now remember, the vendors are mandated, if they're certified in clinical quality measure reporting, to be able to accept data from other systems. In addition, most of the enterprise vendors have developed tools for receiving information from external systems and incorporating it into their clinical quality measure product. Siemens, McKesson, many others have tools that can accept those from vendors, and many of the specialty vendors like T are familiar with sending data in those in that format. So there may be an inherent ability just to easily connect the data that's required from other systems in your environment. But that being said, I would suggest to the group to remember that if you choose to use the sampling method where you send a subset of patients from all payers in for evaluation, you may completely eliminate the need for reconciliation. Furthermore, and it's not on this slide, you have to choose 16 measures from 29. Those 16 measures can be chosen in such a way to really help eliminate or reduce the need for reconciliation. When I say that, what I'm suggesting is that many of those measures have to do with things that happen only during the inpatient stay or only upon discharge from an inpatient status. That means that you really don't need to reconcile the number of patients who got a prescription for X, when leaving the hospital from an inpatient stay, because it's already all in one system. So looking at the clinical quality measures, choosing your method of patient selection, either sampling or all patients, and knowing what your enterprise vendors are going to support for getting information from other systems is going to be critical part of evaluation to figuring out what your best strategy for clinical quality measures is going forward. I talked a lot. A lot of this was very, mathematically based. I just want to review the real the implication of multiple systems for hospitals is that many folks see it as a limitation or a true complication of their meaningful use strategy, when in effect, we see hospitals that are using specialty systems actually doing very, very well without having to do major disruptive changes in workflow, a lot of re-education. They're getting benefits because they're using systems that end users use and adopt. So I'm hoping that what we've shown today is that while there is some increased work for using more than one certified EHR to do a lot of the meaningful use measures, that amount of work is not overwhelming by any means and may actually be profoundly advantageous because you're able to get better numerator numbers out of systems that people are actually using and using robustly. For anybody going to ACEP Scientific Assembly in Seattle next week, we'd love to see you there. Stop by our booth. We're going to be right there as you walk in the main doors. You're not going to be able to miss us. The booth will be there. The booth looks great this year too. But even more importantly, you can't miss us because we'll all be wearing red shoes, and we should stand out pretty well. So come see us. We'd love to talk to you more about meaningful use, about revenue cycle, about our new physician products, physician documentation products, both electronic and non-electronic, T-System EV, comments, criticisms, anything you've got, stop by. We're going to have a large staff there